forces me to think and rethink because of the ongoing discussions in different semis and conferences. And they posed some questions, and the speakers often are, more concerned about how to show their techniques than the principles. So whatever the topics are, they are very much pointed. That if it is courageous spine, so it's not the discussion on the courageous spine. It is the surgery in the courageous spine, and whether you want to have whether you justify global fixation or you can justify just the bone graft. So similarly, all those topics are those which has been nagging my mind, especially in concern with the discussions that takes place in the CME when my students in my college, PG students ask me the questions what to do. So I think there will be a kind of guidelines or a kind of uh, good indications by the learned ones who have been invited and very kindly have agreed to participate in the webinar. And I also think that most of the people who are the listeners have this common problem. So they will have a kind of suggestions, a second suggestion, our opinion from the people who are very much in this spine surgery. So thank you. And I hand over to Dr. Rajiv Anand, who happens to be the executive organizing secretary of the SICON, as well as a treasurer. He is also the secretary of the BOA, and he is the person who is communicating with people.
Thank you. Thank you. Thank you very much, sir. And good afternoon, all the viewers. On behalf of the Spinal Society of Bihar and ASSI, I welcome you all. This is your first webinar in association with Association of Spinal Surgeons of India. And we have 4 speakers with us today. Dr. Shankar Acharya from Delhi, Dr. Samajit Basu from Kolkata, Dr. Gautam Javeri from Mumbai, and Dr. Ajay Shetty from Coimbatore. So we'll be talking on different topics today. So once again, I welcome all the viewers from Bihar Orthopedic Association and West Bengal Orthopedic Association, Madhya Pradesh and Uttar Pradesh Orthopedic Association. So I welcome you all. To start with, I'll invite Dr. Shankar Acharya, and who will be talking on how much surgery is adequate surgery for disc. Dr. Shankar Acharya, please.
Okay, good morning, everyone. And thank you, Dr. Sinha and Dr. Anand, for inviting me. And thanks, Ortho TV, for showing it around. I have to share my screen, isn't it?
Yes.
Has it come?
Yes, sir.
Okay, I think I have been given the job of talking about how do I minimize this pictures. Okay, I think I've got.
Yeah, it's coming full screen.
Okay. My job is to talk about how much surgery is adequate for disc surgery. When I got this topic a couple of days ago from Dr. Sinha, I thought this topic meant whether we should do sequestrectomy or whether we should do an aggressive discectomy. So I have focused my talk a little bit on these, but there are so many issues on disc, though this is the commonest surgery that every one of us does, it still remains the most controversial because every surgeon feels that in his or her hand, the results are good and he has the minimum complications, and the friend next door has probably the largest number of recurrent disc, failed disc, infective disc, disc which needs fusion. So all these issues come in mind. So I will, slideshow nahi ho raha?
So click the right and left arrow, sir.
Okay, yeah. That's fine. So before I start my talk, I think the most important to say is that most disc prolapse will resolve with conservative treatment. I'm not here to say that all disc prolapse need surgery. So I wanted to put this first slide, which says about 90% of the discs we treat them conservatively, and analgesic and anti-inflammatory medicines for a short course of steroids can help for 2 to 5 days or 7 days or 10 days, depending, and the rest as only for pain relief as much as required, and followed relief of pain. Then you start some physiotherapy and strengthening for preventing and further problems of spasm or instability, and creating a good strong back. So these are important things which no surgeon, because I understand from Dr. Rajiv, a lot of postgraduates from Bihar are also listening to this. And so it is important that they must get the message that all disc prolapse should not be operated. Most of the disc prolapse can be treated conservatively. And the only, for example, this patient on presentation has a huge disc prolapse, a large sequestered fragment occupying almost 70 to 80% of the canal. And on conservative treatment, 10 months later, you see that the disc has completely resolved and no symptoms at all. So such patients should not be offered surgery immediately. And there is enough evidence, and we have been practicing for about 20-25 years. And we have seen that most of these disc prolapse will resolve. And sometimes patients with some numbness, tingling, or even mild weakness can be continued with conservative treatment and wait and watch. So the only indications for surgery are cauda equina or intractable pain. I'll come to that later. So does size matter? This was a very interesting because since last 3-4 days, I've been reading up a little more of recent literature. So does size matter? I think all of you should read this paper, though the methodology is slightly skewed in the fact that they have excluded cauda equina, they have excluded lumbar disc herniations which have hard discs, and some more exclusions are there. However, it is a good study to show that all soft disc, immaterial of the size or volume of the disc, and the methodology they have taken is different. You must read this paper to understand that almost even disc prolapse with about 80% canal compromise, more or less are treated conservatively and have good outcome. So their conclusion was that the percent of spinal canal occupied. So sometimes we always see patients or some surgeons or some clinicians say that's a huge disc, you can't avoid surgery and you must go for surgery even if there is no neurological deficit apart from pain and tingling. They said, no, this is very big disc, it was not likely to resolve. And that's not a fact. And we have seen that in our clinical practice also. So the indications for surgery is only cauda equina, motor loss, which is documented, and intractable pain. So the patient really says that I have got a foraminal disc or a far lateral disc and my pain is not resolving in 2 to 3 weeks time, even after blocks or steroids, then he is happy to go for surgery. I think we should offer him surgery. So these in my book are the only indications for surgery. So if surgery, then what surgery? And the topic was that how much disc surgery is enough. So I think at the moment, as our book mails and social media is flooded with news about corona, similarly, when you go to literature, you find floods of literature about discectomy and how to do it and what is right and what is wrong. So you have to differentiate and find out which is a good paper or how it has been done. So I looked into all the microdiscectomy papers and there were found 1528 articles. I picked up a few which I'll discuss and tell you the principles behind how much is enough. So basically we are going to address in our paper these two things. One is minimal discectomy. By that I mean only removing the free fragment and through the annular hole without increasing it, taking out whatever free fragment is left behind below the posterior annulus. So essentially that is minimal discectomy, which is advocated by most of the persons where the patient has got an acute radicular pain with a free fragment, with some free fragments in the disc space. So all you don't have to do aggressive discectomy. By aggressive discectomy means that it's almost making sure that there's nothing left and you are fairly moderate to severely radical in taking out a lot of you keep on going in the disc and coming out, keep on going almost till you find that there's nothing you can get hold if it is on this. So this is what aggressive discectomy means. And minimal discectomy means you take out the disc fragment and you see the defect in the annulus, you put your small 1 millimeter or 2 millimeter pituitary ronger in it, and then take out whatever is free there and without pushing too much strain. Then you put I put in a cannula and I wash the space, and if any free fragment comes out, I take out the free fragments and then I finish. And that is what I normally do in my practice. So historically, how has this two terminology come in? So I need to go into history a little bit to explain to you what is this. So basically, it all started in between the 70s and 80s. When they did discectomy, they meant complete radical or subtotal discectomy, including the curettage of disc space. And I've seen that happen when I was a student, and in sub-regional hospital I used to work. I've seen surgeons used to put in curate to take out disc after doing a hemilaminectomy, so that everything is come out. So that was almost the standard practice those days, way back in 70, 78 period, or 80, up to 80s. Then came some papers which said, and especially Williams' paper became quoted quite a lot, which said that just making a blunt perforation in the annulus tear is enough, and whatever comes out without any incision or curettage of the disc space, so whatever freely comes out, that is good enough. And so that became the conventional microdiscectomy technique, and it was supposed to be gold standard for patients who required surgery for symptomatic disc herniations, because still before that it was radical discectomy. And then Sprengler, this is also very highly quoted JBG's paper, which says only extruded disc fragments and any loose pieces in the disc space with the use of pituitary forceps is to be done. So he said, used the word for the first time, sequester and fragmentectomy, fragment removal into the disc space. So this became the standard of care. So let's look at a case. So this is a 27, I hope you have understood what I mean by discectomy, sequestrectomy, fragmentectomy, and aggressive discectomy. So this is a 27-year-old businessman with back pain and leg pain. He has got back pain, the VAS is 6/10 for 3 months, and he's got left leg and thigh pain for 3 months, which is quite significant. He's got 2-level disc prolapse, as you can see, an L5S1 bulge and an L4-5 bulge and an L5S1 disc, which is sequestered. And he had sequestrectomy done at both levels. He had a free fragment at both levels, and that's all I did. So I do normally minimal in microscopic discectomy, and I take out the free fragment and I put in a 2 millimeter pituitary, and whatever comes out easily, take it out, wash it, and then close. That's what we normally do. 2 months later, he came back to me with more pain, now with more back pain and continuous leg pain when he sits. He says he's miserable, he's not happy. These are his flexion extension x-rays, and this is what it looks like. Now what do I do? You see there's a high intensity zone, so there's a recurrent fragment there in both the levels. So I treated him conservatively. He says the main problem was the moment he sat down, he used to get leg pain. The moment he lies down, he used to be fine. So if I was able to predict that this would have failed, then maybe I would have done something different. So what next? And so I was forced in this patient to go in for a fusion at 2 levels. And I don't think he's very happy either. He is now almost a year, and he still says he gets some referred leg pain, though most of his problems are resolved. But this is not something I want to do in a 27-year-old man. And certainly, so there has to be some issues which we should be able to address beforehand to be able to understand what to do when. Let's look at some literature. Reoperation rates after single level lumbar discectomy is about 12%. So it's about 6 to 12% is reoperation rates after 4 years. And the rate, and if you follow it further, and they may end up to lumbar fusion in about 30% of patients after 4 years of reoperation. So after a recurrent disc, so most of us advocate that after the first recurrence, we normally do a revision recurrent discectomy. But after the second recurrence, we normally then advocate fusion or counsel the patient for fusion. And this seems to be the standard practice of care. So patients at highest risk for, so if we are able to identify which patients will have reherniation, then we will be able to look at them better. Maybe we will be able to offer them fusion right away, or maybe we should be able to do a more aggressive discectomy. So these are the options we have. If just a fragmentectomy or a sequestectomy doesn't work, and these we are able to identify those patients, then we would have done aggressive discectomy in my first patient, which I just showed. They found that patients with annular defects of 6 millimeter or more and females with below 51 years in this paper had a higher incidence of recurrence. And, basically, the recurrent discectomy rate varies from 3 to 18%. So how much nucleus is to be removed is also is important, because if you do an aggressive discectomy, you end up having loss of disc height and back pain. So the incidence of back pain is higher, and then patients are unhappy after discectomy. The leg pain is gone, but they are not able to do anything heavy. If you do a minimal discectomy by doing just removing the sequestrum and the fragments, then you can have a higher reherniation rate. So there is always a dilemma in a surgeon's mind, because if he has a recurrence, then the patient thinks that the surgeon has failed. He doesn't understand the pathology of the disc. This patient feels that the surgeon has failed, and he comes back to surgeon, says that now 4 months down the line, I was all right for 4 months. Now my back has gone into spasm. It's gone to the left side and having severe pain. My surgery has failed. I spent 2.5 lakh rupees. Now what? So this is always a dilemma for a surgeon. So when a surgeon sees a disc prolapse, then he should really think about it. If you look at recurrent disc herniation, long-term back pain versus, and if you compare aggressive to limited, if you find that back pain is more in aggressive, about 19 to 36% people will not be able to go back to their previous occupation of heavy lifting or work if they had that. And if you do an limited discectomy, then recurrent rate is higher than an aggressive discectomy. So this dilemma always persists. So you should be able to identify those groups where you want to do this or that. If you look into long-term outcomes, and you will find that even after doing an adequate surgery, back pain remains in 20 to 30%, leg pain remains in 20 to 30%, and still 30% remain unsatisfied. So in spite of what we think normally that lumbar discectomy gives very good outcome, it may not be necessarily the same in a long-term outcome. And the reoperation rates vary from, as I said earlier, from 5 to 25%. So that is also important. And there are long-term studies to show that, 10-year studies to show that. So what are the so this paper gets quoted very often. This is probably the very high citation index. And that is Eugene Karaji's paper, which said that maybe the answer lies in what type of herniation it is. Whether there is a small fissure in the annulus and the fragment is peeping out of that. So he called that fragment fissure herniation. He said that they did well. Whether there's a large defect in the annulus and the large fragment has come out with a massive annular tear, that is the second type. And then he said the fragments are contained. That means it is bulging, but the annulus is not torn. It's like a tire which is bulging, but the leak has not occurred. And as soon as you rupture it, the disc comes protruding out, free fragments come protruding out, which we have seen in a lot of cases, on most of the cases. And then you have this young bulging disc with a good annulus, with nothing comes out when we put in our disc forceps, and you have jelly-like material, the nucleus coming out with no free fragments. And they do worse according to him. So this group, the fourth group, does worse according to him. So the patient at highest risk for reherniation following a lumbar discectomy in a multi-center randomized trial, they said high risk are among patients with large annular tears and defects greater than 6 millimeter, and females had a higher incidence. How did they measure this 6 millimeter? They said they used pen-filled dissectors with different widths. So if you take a pen-filled of 6 millimeter and it goes in with difficulty, so that is a small annular defect. And if if a larger pen fill more than 10 millimeters or more than 6 millimeters goes in easily and you can move it around, then it's a large annular defect. And anyway, most of us can now know which is a small punctured hole in the annulus and which is a large defect. So that is also there. And they recommended that there should be some technique for annular repair, and they suggested some techniques of annular repair in this paper. So this is a part of 2 papers. So essentially, if you look at systemic analysis and meta-analysis in literature, you will find that the amount of annular tear or the degree of annular tear is unreported or very, very poorly reported in most of the series. So nobody pays much importance to the amount of annulus which is torn or the length or width of annulus which is torn. And that may have really some part to play in the symptoms and recurrence. And then there was a landmark paper by Dr. Rajshekharan, which I'll also quote, which said that all tears are not from the annulus. You can have end plate failure also. And that also forms a large portion of, rather in his paper, it is formed major portion rather than just annular burst. So essentially you are left with these 2 scenarios in clinical practice. In the bottom one, in the L5S1 disc prolapse, I normally do a sequestrectomy, and in my clinical practice, when the disc height is less, there is some amount of back pain. He's been having back pain for many years, and is almost most of the disc is come out. Then I would do a more aggressive discectomy. So this is how I would do in my clinical practice, and this is what I normally do. So these are the different types. So we also think mentally, what are we going to do, and counsel the patient accordingly. So in the aggressive discectomy type, I would counsel him that, look, you have 2 discs which are degenerate. You have a L5S1 disc which is non-functional, and it is also getting degenerate. If I have to do a primary fusion, I may have to do at multiple levels. So I am going to do an aggressive discectomy. You may be left with some back pain. We will do physio, and if it fails, then we will look into things. So we must counsel these patients well. And in the patient with sequestrectomy, I would probably say that your leg pain should go and you should be fine with some strengthening exercise after that. There are some papers, and Bharat Dave is a big from Ahmedabad is a big proponent of primary fusion in selected disc prolapse and in cauda equina. So he's published this, and I think everyone should read this paper. He's done a good analysis of his cases retrospectively, in which he says in cauda equina, where I have to do more or less laminectomy, and there is too much of canal compromise, I would prefer to do a primary fusion. And so that is paper, something which we should do. So there are 3 options we have now, or 4 options. Most will be treated conservatively. Some, when we do surgery, you can do a sequestrectomy and fragmentectomy. Where required, you can do a aggressive discectomy, and then at certain stages, sometimes in cauda equina, in a very large, big disc, young man, high BMI, heavy weight, heavy work, and you may counsel him for a primary fusion. So that is there. But the patient spectrum for all these 4 are different, and that's important to realize and take the message back home. So on the basis of all these studies, what happens to the leg pain? Actually, you will find that just doing a sequestrectomy and removal of the fragment is good enough and associated with a better outcome than with aggressive microdiscectomy at 24 months. So patients who have leg pain and have no other instability features and have no signs or symptoms suggesting that they have instability or going to have back pain, I think this is an adequate procedure for most of the patients. And sequestrectomy was associated with greater improvement versus microdiscectomy, which means aggressive discectomy after 2 years in more motor deficit and sensory hypoesthesia. Health quality was also better with this sequestrectomy. So all those scores, the ODI and SF36 were better with just doing this for selected cases. And that's important to keep in mind. However, when you do just sequestrectomy and fragmentectomy, you must counsel the patients about recurrent disc herniation. So patients who are prone for recurrent disc, you should be able to identify in your initial counseling. Those who are diabetic, those who are obese, those who have multiple level prolapses, those who have sagittally oriented facets. So you have to take all those things into consideration, and you may have to counsel them. So he doesn't take a recurrence as a complete failure and failure of the surgical procedure. And so that is important.
I think we will have less time for questions.
Just a few more slides. I'll almost, the procedure related complications are found that in microdiscectomy, you have just sequestrectomy, you have less complications, obviously, because you're messing around lead, so you get less dural tear. And this is one of the landmark papers of Rajshekharan, which said that more than 60% patients actually have disc prolapse with end plate fractures, rim fractures. I think Ajay Shetty, who is also participating in this webinar, is author of this study, and this is a very good study. And this is the first time they showed in vivo that end plate fracture is probably a primary cause of large disc prolapses, and nobody seems to have noticed it because primarily two reasons. One is we do mainly X-rays where it doesn't show, and second is when we do MRIs, which also doesn't show in the cuts with the disc we take. We don't take rim cuts or we don't take fine cuts. So only if you take fine, thin slices of CTs, you will realize that these are important findings and they're associated with more than 50% of disc prolapse. And so obviously there would not be any healing, and if they heal with aberration. They also showed long-term follow-ups of healing of these, but the large annular defects obviously would not heal with this. So take-home message is well-designed randomized trials obviously are controlled required. So we need to look at what are the cases, which is a white apple, which is a red apple, which is a pink apple, which is a green apple. So we need to see which are these patients and then decide as to whether we should do aggressive or just a sequestration. Thank you. So this is the message I heard Dr. Mohit Bhandari and Raja, he was talking. I like this message. I made this my duty also. I was saving time during this corona crisis. Thank you very much. I'll take questions.
Thank you.
Now I exit. How do I exit?
Yes, sir. Stop sharing, sir.
So I'm not as good as Dasu and Gautam in this.
Can I have a question to Dr. Shankar?
Yes, sir.
Yeah, I also had a question, but you go ahead, Dr. Sinha.
Yes.
The participants were supposed to ask questions. Anyway.
That will be done by Dr. Rajiv Anand.
Okay.
My question is whether you can predict the health of the disc so that you can decide better whether you are going to do only fragmentation or the aggressive disc.
Well, health is a broad terminology. When you say health, what does it mean? So essentially, unless you are able to have good quality MRIs, and so it's very difficult to say what health of the disc means. I think it's a very broad term to say health of the disc. But essentially, morphologically, if you find no end plate changes, if you find no modic changes, if you find the disc height is well preserved, if you find only single fragment, then that is probably a disc which would last by just doing a sequestrectomy or a fragment. Then a disc which is degeneration, which has associated acid arthropathy, which has lost its height, there is loss of lumbar lordosis, there is adjacent disc failure, then they are unhealthy discs. And so definitely patients with disc disease like Scheuermann's or others, so they may have unhealthy discs, sporal nodules, multiple, so they have unhealthy discs. So also we can understand this from MRIs.
The idea is, my question is that by seeing the X-ray, when you are planning, say, to operate upon the L4 pipe, by seeing the cut sections of the L4 pipe on MRI and different mode of, can you predict that you are going to have only a little bit of this out, or you have to have, a scrapping of the entire disc?
No, I think you can find out. I think my lecture was completely based on the height, looking at what are the factors there. So if you have a fragment and if you have a large disc and if you have no end plate changes, then yes, you can just do a sequestration and come out.
Okay, thank you.
Yes, Gautam, you had a question.
Yeah, Shankar, you mentioned about the differences between aggressive discectomy and a sequestrectomy.
Yeah.
Now, the problem in literature, as I have understood, is that there is a sequestrectomy which removes the sequel, and there is an aggressive discectomy, which is a term from the older ages where we were very aggressive. We used to curate the end plates and all, which we no longer do. Most of us nowadays, if we do a discectomy, it is a sequestrectomy, plus just opening up the annulus and checking for loose fragments in there. So, do you think that the results, you mentioned a number of outcomes and said aggressive discectomy was bad, but aggressive discectomy, I don't think any of the spine surgeons do any today.
Yes, not anymore, but these have compared the earlier ones which were doing, but still some spine surgeons would give a linear incision in the annulus. So traditionally, the methodology which has been, I read that paper up, where he says sequestrectomy and fragmentectomy, he says remove the free fragment and then through the available annular tear, you put in your pituitary pituitary ronger of the similar size. So do not make a cruciate incision, do not make a large annular incision, and then go all over the place to take out the disc. So you may be surgeons now may be doing somewhere like limited or less aggressive conventional discectomies. I wanted to compare that with that. So that has also been mentioned. So sequestrectomy and fragmentectomy means going through the present annular tear and just using a 2 millimeter or 1 millimeter pituitary and taking out whatever is freely coming out, putting it in a cannula, washing it out and coming out. However, a more aggressive approach would be to put a long linear annular incision, a cruciate or a straight, and then using in right angle dissector, curate or chelicid plunges up to 4 millimeters, 5 millimeters, then it becomes more aggressive. So it's always a spectrum. It can't be just one end point. It is a spectrum. So if you lean towards that end of the spectrum, then you are probably doing a more aggressive discectomy. And if you lean to this end of the spectrum, then you are doing a sequestrectomy and fragmenting.
Dr. Shankar, there are, a lot of these recommendations come from countries where there is government healthcare is the primary method of healthcare, or people understand. In our country, one of the problems that we face is that maybe if he has some back pain at the end, he will accept it. But if he gets a recurrent disc prolapse in 3 months or 6 months, he is going to blame the surgeon for having created it.
Yes,
so which
that's
is
the dilemma. That's the dilemma.
So which is a better alternative in your practice? Do you think that you would rather face a patient saying that you did not do a proper surgery primarily, or one who is complaining of a little bit of back pain and leg pain which can be controlled with physiotherapy? What advice do you actually, I mean, it's good to know the literature, but what advice would you give to the young audience who's watching you?
So in the young audience, I am watching me, and my fellows are also there on this watching me. They would know that most of the time what we do is, if the annulus tear is just a point, we would not make it more than a 0.6 millimeter tear. So we will use up to 1 or 2 or maximum 2 millimeter, 2.5 millimeter pituitary. We don't go beyond that. And I use these are the sizes. Very rarely would I be aggressive. And sometimes when the disc height, as I showed 2 cases, sometimes when I predict that this patient may have a recurrence, he has a bad social history, he may be a litigant patient, he may be a problem, then I will tend to the other end of the spectrum, trying to be a little more aggressive. Where I know that his pain is only because of this fragment and is a fairly clean meat and a young patient who suffered a first disc prolapse.
You have got more questions? Dr. Rajiv, you have got more questions?
No, at present there is no questions.
Then we should move to the next.
Yeah, so we'll go to the next topic. May I invite Dr. Soumyajit Basu, and who will be talking.
Thank you very much.
Thank you, sir. Thank you, sir. So may I invite
Dr. Shankar is requested to remain.
Okay.
And
I've got more questions for him.
And he'll be talking on management of C1, C2 fracture displacement, role of conservative management, imperative indications for fixation of C1, C2, even in old case. Dr. Soumyajit Basu, please.
Good afternoon, everybody. Sincere thanks to Dr. Sinha and the rest for inviting me to give this lecture on management of C1, C2 fracture displacement. Am I audible and is my screen visible?
Yes, sir, yes.
Right, so I'll stick to time. I'll try to finish off the lecture by 20 minutes so that you can take questions after that. So what I'll try to cover is, the pre-hospital management issues, types of upper cervical injuries, details of each types with management issues, clinical examples of important types, and put across some final concluding remarks. To start with, let me say that C1, C2 injuries are not so uncommon as we think they are supposed to be. And even common orthopedic surgeons who do general trauma, they would also encounter this. But a high index of suspicion gives us relief from missed injuries and neglected injuries. I would not talk a lot about pre-hospital and hospital management, but we all know that airway, breathing, circulation, the basic ABCs of trauma care needs to be incorporated with another C, and that is to immobilize the C spine and to make sure that you log roll the patient. Evaluate the patient with clinical, radiological, extra-CT, MRI, and then only treat it either operatively or non-operatively. Now, cervical spine injuries are basically two areas of different pathologies, different treatment. The upper cervical, the C1, C2 injuries, and four types are most importantly described. One is the atlas fractures. Next is the C2 fractures, mostly the odontoid fractures. Number 3 is the hangman fracture, and number 4 is the C1, C2 rotary subluxation. So the entire gamut of discussion of C1, C2 injuries would be more often than not localized to Jefferson fracture, odontoid fracture, hangman fracture, and C1, C2 rotary subluxation. Occipital condyle fractures, just to mention, are mentioned for completeness. They are rare injuries, usually conserved, but remember that atlanto-occipital dislocation is a very rare injury, less than 1% in most of the level 1 centers, and they are potentially fatal. So coming down to atlas fractures, we all know that type 1 and type 2 are innocuous injuries, with type 1 only involving the posterior arch, type 2 the lateral mass, and all of them are conserved. Only one thing to be understood is the avulsion fracture of the TAL, the transverse atlantal ligament. As you can see here, there is a bony fragment which is an avulsion fracture of the attachment of the transverse ligament, and that if it is bony, it is usually conserved with a halo, and if it is ligamentous, then they usually present with C1, C2 instability, and those are very difficult to heal unless immobilization by surgery is done. So the type 3 fractures are most important, in which they are either a 3 or 4 part fracture. As you can see that there is a fracture anterior and posterior to the lateral mass in both right and left side, and this is equivalent to a burst fracture. And the Jefferson fracture, as we all know, are earmarked with a spread of lateral mass in the open mouth epiviews or in the CT scan, where the total amount of lateral subluxation in both right and left together is more than 7 millimeters. And if it is displaced, we usually use a halo waist, and undisplaced, a molded collar is enough. I would stop at this point in time and tell you that Jefferson fracture and burst fractures of the atlas do not always need surgery. Most of them do extremely well with immobilization by non-surgical methods. Now coming to the C2 fractures, the most important fractures are the odontoid fractures, and the Anderson D. Alonso's classification still holds true. With type 1 and 2, type 1 is an avulsion of the tip of the fracture. It's a rare injury. It's a very, very simply treated innocuous injury. It doesn't require much of immobilization. Also, possibly a couple of months of collar is enough. Type 2 is a fracture of the base, and we all know that the union rate of this fracture is very high because there is a watershed line, because of the vascularity, and because also the fact that embryologically speaking, they have two different origin of development, the body as well as the odontoid. And if they are simple, they are type 2, and if they are complex or comminuted, they are type 2A. And finally, the type 3 injuries are fractures to the vertebral body, including the vertebral body. And as we all know that as this fracture line dips into the cancellous vertebral body, they're usually stable, and most of them heal without any surgery because of the large fracture area. Now, important here is to realize that if these are the C1, C2 joints, the fracture line usually does not reach or does not disrupt the C1, C2 joints in a type 2 fracture, whereas in a type 3 fracture, they might involve the joints. The problem is if they involve both the joints, they are sufficiently deep enough, so a guaranteed conservative care should heal. I mean, the treatment is usually by conservative means, and a good result is guaranteed. Whereas if it involves one joint and the other is spared, That is something between a type 2 and a type 3, and Goring has published on this, and he proposes that these incomplete type 2 or incomplete type 3, whatever you say, might require surgery because they are potentially unstable. So as I told you, type 1 and type 3 are non-operative, and one of the examples is an elderly gentleman. Remember that many of these rheumatoid fractures are by trivial trips and falls by elderly gentlemen or elderly ladies, and they are very common and should not be overlooked. Please get an open mouth spine X-ray and a lateral inflection extension to prove or disprove whether you have a type 2 or type 3 rheumatoid fracture, usually treated with a halo. The question is type 2. As I've said before, they have a more than 80 to 90% non-union rate if it is displaced. And if it is undisplaced, you might go on with a non-operative treatment. This is a unicortical fracture. If this is one cortex intact, this is one cortex intact, one cortex gone, obviously a halo is enough. What happens if the displacement is more than 4 millimeters and the angulation is more than 10 degrees? Then there are two possibilities. Either it is reducible. In that case, an anterior rheumatoid screw fixation is the treatment of just if they present to you early. And if it is irreducible, then primary arthrodesis of C1, C2 joint through the posterior approach is the treatment of choice. Give you an example in which you can see that this is an anterior rheumatoid screw fixation which has been done for this type of fracture. This is slightly displaced, as you can see in the MRI, and this is not comminuted. This is presented to be fresh, and so the treatment was a direct osteosynthesis with an anterior rheumatoid screw fixation. And this is the one of the contraindications, other than the fact that the patient presents to you later if it's a comminuted fracture, if it is irreducible, that is a reverse obliquity. That means if the fracture is of this obliquity, that means anteriorly it is much lower down than its posterior aspect, they are potentially unstable, and the lag effect of these screws actually turns them into an unstable scenario where the proximal fragment slips forwards. So this is a contraindication. A reverse obliquity is a contraindication for type 2 rheumatoid screw. And this is a very old case, just to tell you that wires should not be thrown out absolutely. If you can wire them, this is irreducible, as you can see, and this was primarily stabilized with a posterior wire and a halo immobilization for 3 months. The old non-unions are always treated with primary arthrodesis. Many of them, and as we all know that Alan Crocker, who we invited for the ASICON of Calcutta 2014, is one of the pioneers and published the first of a series of patients which he had 25 non-unions and improved that they often have progressive myelopathy and they should be operated upon. And primary arthrodesis of posteriorly, as you can see, with a heart shell or a Rainsford loop can be done, and a primary arthrodesis through a C1, C2 transarticular screw fixation for a comminuted fracture is shown here. I will show you subsequent examples of cases in which we could do anterior and posterior and a little bit later. Now let's go on to Hangman's fractures. Now Hangman fracture is basically a traumatic spondylolisthesis of C1, C2, which means that there is usually a pars fracture of the C2. Now, it is important to realize that C2 pars is an extremely important structure giving stability to the C2 vertebral bone. If it is minimally displaced, that means less than 3 millimeters of translation and no angulation, and there is minimal motion flexion extension, that's type 1. And type 2 and type 2A, these are potentially unstable, might not be frankly unstable. Type 1 is potentially stable, it is not unstable. So type 2 and type 2A depends on the mechanism. You can see that type 2A is a flexion sort of injury in which there is an angulation of 10 degrees, whereas type 2 is more of a hyperextension injury where there is no angulation. You should avoid traction in these patients in the type 2A because there might be distraction because of the loss of C2-3 disc. C2-3 disc is usually preserved in in type 2, and it's usually disrupted in type 2A. So 2 and 2A you might get away with a halo brace immobilization, or you might have to operate on them. There is a little bit of gray zone depending upon whether you have other injuries or not, depending upon how much of displacement is there on flexion extension. This is one of the patients of type 2 displaced fractures, which we treated surgically with an anterior C2 fusion, and they may also be treated by a posterior pars repair or pedicle screw fixation, which are posterior techniques which have been described. Now in type 3, you have a combination of pars fracture as well as a C2-3 facet dislocation. I'll give you an example of this elderly gentleman who had not only a C2-3 facet dislocation, as you can see that this facet is bare and this is normal. So this is a unilateral facet dislocation of C2-3, which we treated like a hangman, and we put him on traction and did an anterior job with reasonably good correction. So a few examples of other modes of treatment for odontoid fracture before we go on to C1.
आवाज फक्त ऐकू येणार आता. हां, मी व्हिडिओ बंद केला. पाहिजे?
If we go on to this X-ray, as you can see that this is a hangman's fracture and there is not much of instability. If you look at the CT scans well, you can see that this is a CT scan which shows you that the pedicle on this side is fractured and there is a pedicle fracture on this side also. And there is a large comminution there. So in this patient, considering the fact that we did not have much of instability on flexion extension views and considering the fact that he is neurologically intact and there is a large fragment which is potentially going to heal going into the vertebral body of C2, we treated with the halograft traction. And this is extremely important to understand the CT scans well. So this is the sagittal CT, which is in the mid-sagittal section, and this is the parasagittal pedicle cuts, where you can see that there is a large gap there, and this pedicle fracture extends into the vertebral body, and this pedicle fracture is minimally undisplaced. So this is a patient whom we did a conservative trial, and the fact that he had an avulsion injury there also in the C2 vertebral bone made me sure that this is going to heal. Now let's go into C1, C2 rotary subluxations. There are also 4 types. In type 1, you can see basically there is a capsular destruction. Remember, this is an injury of the C1, C2 joint. And usually a rotation injury is there. There might be additional translation injury as we come down later. So type 1 is a capsular ligament disruption in which you find that the odontopad is the pivot over which C1 rotates on C2. So one of the C1 lateral mass goes backwards and the other goes anteriorly, and usually the flexion atlantodense interval is less than 3 millimeters, which basically means that they are stable. If it is more than 5 millimeters or 6 millimeters, they are unstable. So this is a reasonably stable injury. Type 2 is associated with the transverse ligament tear, and in this case, as you can see, that one of the C1 C2 joints remains in its position, and here the peg or the axis of rotation is this intact C1 C2 joint, and the other moves on this as a pivot. The C1 moves, and on one side you can see it moves ahead, and there is flexion instability of 3 to 5 millimeters. This is a gray zone. Many people would conserve, especially in children, if you just immobilize them, if they arrive to you fresh, they can be easily conserved, and they usually do well. Type 3 and 4 are quite dangerous injuries because there is an anterior subluxation or a posterior subluxation. You can see that both these C1, C2 lateral masses move forwards, and the flexion atlantodense interval is more than 5 millimeters. And type 4 is a backward translation. You can see this is an odontoid fracture associated with it and leading to a backward translation rather than a forward translation of C1. And in these cases, as you can see, type 3 and 4 are rare but potentially fatal and may be very dangerous. For the treatment of them, if they come to you in acute stages, they usually reduce well, and a closed reduction with a halo vesting mobilization usually solves the issue. They are commoner in children, and many of them present early. But if they present late, it might be a problem. Type 4 usually treated as the odontoid fracture as a primary treatment, and treat the odontoid fracture in the lines as we told you right before. If it is chronic, in our country, they do present with 3 to 6 weeks after the injury, occasionally 3 months. If at all you have to reduce, you have to reduce it. If at all you can get a partial improvement, a partial reduction with prolonged skull traction, you might achieve that. And all acute and subacute rotary subluxation should be treated with the halter traction. So if it is chronic or delayed presentation, you might treat with skull traction followed by halo vest immobilization. Remember that recurrences, or if they're late presentation, then you have to do a surgical fusion to C1 joint. So this is a picture of a halter traction young patient came too early. And one of these examples, as you can see, many of them might have Rizal syndrome or pharyngitis. Many of them do give a history of trauma, especially in school, and they do extremely well with a couple of weeks of traction followed by halo vest immobilization or a traction or a molded Philadelphia collar. If they present to you late, as in this child, we did put her on traction and she reasonably reduced, but she did have some flexion, some lateral bending deformity, which was there after the halo was removed. But over a period of time, she's got very well adjusted and she's completely painless. As opposed to this patient who presented to us late, as you can see, there is a significant rotation, and this is a patient we had to go in along with a transverse ligament injury, to go in initially put on skull traction and then put her on a C1 C2 fusion with transarticular screws. So this is the pre and post-operative patient. Remember that in these sort of patients, the vertebral artery course has to be remembered well, and the tortuous artery is always a danger which you might have to consider before planning for surgery. This is the pictorial representation of how to do a C1 C2 transarticular screw. That is the trajectory, and the Goel-Harms technique, you put in individual screws that C1 lateral mass and then towards C2 pedicle and get a proper reduction. A few examples of C1 C2 instability. Here it's treated with a transarticular screw and a posterior sublaminar wire. This is actually a cable. It's an Atlas cable, and that is how the graft is fixed there with a solid position there, and you can see that how unstable it is. Similarly, we can treat, this is actually a Marfan patient with a huge lot of capsular laxity, and you can see that there is a huge C1 C2 instability, and here we could reduce this and we could put in C1 C2 pedicle screw systems like a Goel-Harms technique. Now, what happens if it comes to you late with a completely dislocated odontoid? Here, this might be a congenital problem. This might be due to a prolonged history of a trauma in childhood, and in these few patients we might have to do, we might not have to do. In these patients, this was pretty old, and we were not so comfortable with all these posterior techniques. It's about 10 years back when Atul Goel had not been so popular. Nowadays, we would treat most of them posteriorly, but in this case, we did an anterior odontoidectomy followed by a long segment posterior fusion. We did publish a series of 28 cases 10 years back, and it's worth noting that I will not go into the details of this, but worth noting that most of them would be treated conservatively and very few of them required surgery. Only in these odontoid screw fractures and a few of the handbands that we operated upon, rest of them were concerned. So to conclude, upper cervical injuries are not as uncommon as we think. Pre-hospital treatment has to be emphasized. Proper clinical and radiological evaluation is a must to diagnose the exact nature of the injury. MRI does give us information regarding the ligamentous structures, regarding the status of the cord, signal intensity changes of the cord, but a CT actually shows us the bone geometry much better. I would recommend a CT of each and every one of the C1 C2 injuries. Many of them can be treated conservatively. These conservative mechanisms are just traction or halo or collar, which any general orthopedic surgeon can put in. Operative treatment is technically demanding, but believe me, it's reasonably safe and predictable and has a big outcome over a thorough understanding of the complex needs. Thanks for your attention.
Thank you. Thank you, Dr.
Thank you, sir. Very elaborate presentation. One question came from our member, Nishit. He has asked that how you assess that there is a C1, C2 instability when there is a fracture dense the odontoid type 2. So how you assess like some of the posterior fragment which causes instability. So how you assess the instability?
Assessment of instability of the C1, C2. is always by radiological and clinical means. Well, clinically speaking, occasionally they come with neurological deficit. Now, it is not very common, but if they at all present with neurological deficit, definitely they are supposed to be unstable. On clinical examination, if you find that C1, C2 rotation is extremely painful, it might be unstable. Now, on radiological grounds, more than clinical grounds, on radiological grounds, if you look at an X-ray, flexion extension via an open mouth AP and a laterally neutral and a supervised flexion extension, provided it doesn't have neurology, is a very good marker of instability because the atlantodense interval and the angulation of the C1 and C2, these are the two things which needs to be noticed. If there is more than 5 millimeters of atlantodense interval opening up on flexion views or even on extension views, if you find that the odontoid fracture is getting displaced posteriorly, or if you find that the C1, C2 spinous processes are angulating too much, then these are markers of instability. Along with that, in the MRI, if you find that there is a signal intensity change in the transverse atlantal ligament, or in the CT scanning, there is a huge lot of combination of C1, C2 joints, then these are frankly unstable.
I have got a question to Dr. Basu.
Yeah.
There was an inbuilt question in your topic, and that was that when the patient is doing well, rather he's coming in the OPD, walking, and not much of complaint except little bit of pain and something. And after 4 weeks or so, and whatever presentation you have done, it is I gathered that it is when he's coming, reporting rather early. But if he reports after 4 weeks or so, you change the line of action or your suggested plan of action, or you do the same.
So, it basically depends on what sort of pathology. As I showed you, that there are 4 major pathologies of upper cervical injury, 4 main types of injuries. Now, if it's a 4-week-old type 2 displaced odontoid fracture, definitely surgery is the choice. If it is an unstable fracture, even an unstable hangman's fracture which is presented to you late after 4 to 6 weeks, requires surgery. Atlas fractures usually do not require surgery. C1, C2 rotary subluxation, if they are type 1 or 2, that means minimally displaced, they do not require surgery even if they present after 4 to 6 weeks. But if it is a type 3 or type 4 C1, C2 rotary subluxation in which you have additional odontoid fractures or where there is an atlantodense interval which is more than 5 or 6 millimeters, they are definitely candidates for surgery. So it depends on the pathology which you are looking at. Many of the pathologies of upper cervical injuries are inherently stable. They do not require treatment even if they present late. But some are inherently unstable, might go on to progressive deformity and neurological deficit later on. These are the candidates for surgery.
Dr. Basu, excellent talk. This is Dr. Gautam Zaveri. The question is that in our country, it is well known that almost 30% of primary injuries to the upper cervical spine are missed originally. Even if the patient, often the patient presents late, but more commonly when the patient presents following a blunt trauma, the injury is missed or misdiagnosed, and that is the most common cause for late presentation. And when it presents late, patients come with neurologic deficits, deformity, and the surgery becomes more complex or treatment becomes more complex. What is the protocol you would advise the audience today when a patient with a blunt trauma, fall from a height, a motor vehicle or accident or a fall of object on the head comes to their clinic? How should they go about assessing which patients require further x-rays, a CT scan, MRI, which patient can be sent home? Can you give us some guidelines?
I think that was an excellent question, Gautam. For the general orthopedic surgeons, who I believe forms the crowd of today's audience, we must realize that there are 3 subsets of trauma patients which you are going to see, in which you need to rule out cervical spine, especially upper cervical spine. First is all polytrauma patients. Polytrauma definition is something that is well known to everybody, but if you find that you are called upon to see a polytrauma patient, a cervical spine X-ray or possibly a screen CT is extremely important. So that is one subgroup. The second subgroup is all unconscious patients. Unconscious patients having any skeletal injury which you have been referred to or which you've come to look upon, whether it's an august duty to screen the cervical spine clinically as well as radiologically to find out the telltale signs of upper cervical injury. And third is all patients of head injury needs to be looked for cervical spine injuries. Just before leaving the unconscious patient, I would tell you inebriated patients who are not truly unconscious, but inebriated patients also, that means somebody is under the influence of alcohol or drugs has come to with any sort of trauma, that is a patient also you should screen for cervical spine injuries. Finally, as I was telling you, all patients of head injury should undergo a cervical spine screening test. Finally, this is not usually very common, but I will just take 1 minute to tell you, pediatric spinal injuries are not that common. But if you have a pediatric spinal injury, that means there is a 1/3 chance that it will be in the upper cervical spine. So make sure that if you get a pediatric spine injury, you have a very thorough examination of the cervical spine.
Okay, Dr. Rajiv, do you think there's no time for question or would like to move to the next?
One more question has come from to Somajit Basu, that what are the indication of transarticular C1, C2 fixation, and what is the danger of vertebral lateral in doing that? And has the learning curve is more, or it is advisable to do it?
So both the surgeries which have been in vogue for the last few years for stabilizing the C1, C2 joints are, first is a C1, C2 transarticular screw fixation described by McGurl, and the second is a C1, C2 pedicle screw or a lateral mass of C1 and a C2 pedicle screw fixation as described by Atul Goel and Jogrel Hams. Now, the prerequisite for a C1, C2 transarticular screw fixation is a complete reduction of the C1, C2 joint. If it is not reduced, you cannot do this. This reduction usually is closed reduction. Occasionally, it might have to be an open reduction. The advantage of McGurl is that you can do it virtually not opening it up or not opening up the joint, whereas in C1, C2 Goel-Hams technique, you have to see the joint, you have to coagulate all the blood vessels. That area needs a little bit of technical expertise to be opened up because this is extremely filled with all sorts of blood vessels because there is a lake of chain of blood vessel all around that joint, which needs to be meticulously coagulated, and the C2 ganglion comes in the way, which needs to be either sacrificed or retracted. So C1, C2 transarticular screw fixation is a technical difficult procedure. The trajectory is difficult, especially when you have an upper dorsal kyphosis. It is not easy. So whoever has asked this question, I would suggest that both these surgeries can be taken up with proper training. Not that they are very, very, very dangerous surgeries, but they definitely require training.
Thank you so much, sir. So we'll move upon the third speaker. So may I call upon Dr. Ajay Shetty, and from Coimbatore, and who is be talking on surgery in Caries spine, role of global stabilization versus bone graft only. Dr. Ajay Shetty, please.
Not audible. Dr. Ajay is not audible.
Hello, Dr. Ajay Shetty.
Hello.
Can you hear us? Dr. Ajay Shetty?
Yeah, sorry.
Yeah, you just unmute, sir.
Yeah. Basically, my talk would be on tuberculosis of the spine too, and it will cover optimizing outcome. Slides are not moving. Yeah. As you know, tuberculosis of the spine is one of the most commonest infection of the spine we see in Indian practice. It can involve from the occipitocervical spine to the thoracic, lumbar, and the lumbosacral junction. It could be a classical paradiscal type of tuberculosis, what we see usually in a day-to-day practice. But however, it's not uncommon to see central or the body type of tuberculosis in a significant percentage of the patient. Why tuberculosis is important is basically because it's a curable disease. If we treat these patients appropriately, correctly, and early, it can be cured without, at least majority of the patients can be cured without any major significant disability. We all know that tuberculosis, as it starts, there is a osteolysis, which will lead to, and also in decreased nutrition to the disc space, which will lead to a collapse of the disc space and the vertebral body collapse, and leading on to a local kyphosis retropulsion abscess, which can lead to a spinal cord compression and neurological deficit. And we also know that the tuberculosis is an anterior disease, and when it heals by kyphosis. Therefore, some degree of collapse and consolidation is to be expected. And if the degree of collapse and consolidation varies on the amount of the vertebral body destruction. Therefore, if you have a situation like this, in the lumbar spine especially, it will heal without much of a sequelae. There could be a loss of lumbar lordosis. There could be an increase in thoracic kyphosis, but if the bony destruction is less, it usually heals without any major sequelae. But however, if you don't treat them, or however, you do not know which are the patients to be ideally treated, it can lead to a significant kyphotic deformity. As this patient was diagnosed to have a tuberculosis of the spine, and if you can see, there is all the signs of spine at risks. That means it's significantly unstable, kyphotic, there is a translation. But however, she was continued to be treated with medical drugs and ended up having a kyphotic deformity and presented to us later on with a neurological deficit. Therefore, it's important to identify which are the patients to be treated conservatively and which are the patients to be treated surgically. Why it is important? It's also now, it's a notifiable disease. Therefore, the government of India has said that tuberculosis is a notifiable disease, and it's imperative that we have to follow the RNTCP guidelines in the management of spinal tuberculosis. And every patient we have to notify to the government whomever we are treating with spinal tuberculosis. Now coming to the first important aspect, the common question that is asked, is biopsy necessary? I would without hesitation say yes, biopsy is necessary in all patients with suspected spinal tuberculosis. If patient comes with a lesion where there is no major bone destruction, where surgery may not be indicated, we can do a percutaneous biopsy. But however, if the patient presents to us late with neurological deficit and significant kyphosis, we can do the biopsy and surgery at the same time. TB is a great mimicker. It can be a pyogenic one, it could be eosinophilic granuloma, it could be lymphomas, it could be other malignancies. Therefore, it becomes imperative that we have to do a biopsy before we are sure it's tuberculosis. There could be certain exceptions when the patient cannot afford, when there is no facilities in a scenario, when patient presents with the classical MRI features, there could be an excuse to say it's a presumed tuberculosis and can be started on anti-tuberculous chemotherapy. I'm not propagating that you can treat all patients without a biopsy, but my advice is to do biopsy whenever that is possible. When you do the biopsy, it's important to send for gene expert, TB culture, histopathology, and pyogenic bacterial culture. You have to send it always. If you're in the endemic area of fungal, or you suspect, the radiologist suspects fungal, you can send fungal culture. Traditional smears are usually not positive in spinal tuberculosis, unlike in pulmonary tuberculosis. As you are aware, spinal tuberculosis is basically a paucibacillary disease, and the chance of getting a traditional smear positivity is very, very less, unlike a pulmonary tuberculosis, which is a multibacillary disease. Therefore, you can get a positivity in a sputum culture. Biopsy from where? Ideally from the lesion. It should be image guided and CT guided. And I prefer to do it transpedicular. But however, if there are an abscess, presence of a cold abscess, like a situation like this, you can do an aspiration, either ultrasound guided, as in this scenario, whereas in a scenario like this, you don't need an ultrasound. You can aspirate, send it for gene expert, and if it's positive, MRI features are classical, you can treat it with anti-tuberculous chemotherapy. Coming to the second question, what chemotherapy? It is a multi-drug therapy. Duration is now a current recommendation from the National Tuberculosis Research Center. IRTCT guidelines is basically about 9 to 12 months. It should be a daily therapy. Intensive phase is 2 months of HRZD, and the continuation phase in India is about 7 to 10 months. That is making up to 9 to 12 months. Currently, what is indicated that we have to use 3-drug regimen, INH, rifampicin and ethambutol because 30% of the Indians are found to be resistant to INH. Therefore, what do you do in follow-up? You have to look at ESR, you look at LFT, you have to look at weight. And usually there will be a progressive increase in weight. ESR may not come to normal, but it can remain about 30 and 40. But if the ESR is about 80 to 100, then you have to be much more careful. That means it may be non-responsive. When you do LFT, to cut down the cost, it's not necessary to do the whole LFT. What is necessary is basically SGOT, SGPT, and bilirubin. That will give you an idea. Whenever the enzyme levels are doubled, then you have to stop the drug and you may have to go to a alternative chemotherapy, the drugs which not cause liver dysfunctions. It's also advisable to do a uric acid. What are the signs of healing? Clinically, weight gain, sense of well-being, and the absence of pain. As I mentioned, ESR, most important is plain radiographs. The two most important thing for me is looking at the patient face, how the patient is walking, number one. Number two, weight gain. Number three, looking at the X-ray. X-ray may not show any evidence of healing for 3 to 4 months. But what you are looking for in the X-ray whenever the patient comes is to see that there is no further destruction or kyphosis that is happening. The initial 3 to 4 months in the X-ray, there is no further progression. Whereas after 4 to 8 months, you can start show signs of healing like bone formation or ossification and a slow bridging of bone across the affected area. How to prevent drug failure? Counseling is the most important part. You have to speak to the patient in the beginning, counsel that you have to take the drugs for a period of 9 months to 1 year. And it's very, very important, counsel them as to how to take the tablet. Most importantly, the dosage has to be based on body weight. The patient compliance is the most important aspect. And there are studies which have looked at vitamin D and vitamin C. Most of these patients will have a reduced vitamin D. It's not going to cure the condition, but it has been found that giving vitamin D and vitamin C might also help in better healing of the generalized condition of the patient. It boosts the immunity, they are antioxidants, and it's cause a better healing of the lesion. What did chemotherapy do? It cured the disease. It causes a spontaneous resolution of the cold abscess. And also, as you can see, it heals without any major complication. Therefore, we all know right now that uncomplicated spinal tuberculosis is a medical disease. But however, that is uncomplicated means there is no deformity, instability, and significant neurological deficits. Whereas a complicated tuberculosis, whenever there is a deformity, instability, and neurological deficit, is a totally different entity. Therefore, coming to the third point, when do you do surgery? There are many indications, but commonly neurological deficits, whenever there is a deformity greater than 30 degrees, the spine at rest signs, instability, and diagnosis in doubt. As we all know, Dr. Tully's seminal work, wherein he brought about the middle path regimen, wherein patients with milder neurological deficits who are non-progressive deficits can be treated with anti-tuberculous drugs, and we can look for their resolution. And these are the patients Dr. Anil Jain correlated and found that patients who improve with neurological deficit on anti-tuberculous chemotherapy on MRI, usually it is basically that the neurological deficit is not because of mechanical compression. Number one, not because of significant kyphosis. The neurological deficit is usually seen in a relatively stable spine, and the deficit is because of cold abscess. Therefore, when you have this scenario, in the MRI, you see a cold abscess. There is no significant kyphosis or bony compression. Patient has got an early myelopathic signs or neurological deficit. They are the one who can be safely treated with anti-tuberculous chemotherapy and observed carefully to look for improvement. Instability is basically the presence of instability, the spine at rest signs. But the most important thing we have to look at is pain persisting out of chemotherapy, and is applicable mainly for ambulatory, for elderly patients. Studies have shown that in elderly patient, when they lose their ambulatory capacity, they go into a catabolic state, the pain catabolic state. Therefore, we have found that if you stabilize them early, either by open or percutaneous method, along with anti-tuberculous therapy, their recovery is much, much faster. And these are the various risk factors for severe progression. The age less than 10 years, when the vertebral body loss is greater than 1, when the deformity is greater than 30, junctional lesions, and the presence of spine at rest signs. Surgery, when you come, which surgery to do? That's the question which Dr. Sinha wanted me to answer. The goal of the surgical treatment is decompression. Number one, deformity correction. Number two, number three, stability by reconstruction of the anterior column and stabilization of the spine with instrumentation. This is the basic goals or the principles of management, surgical management of spinal tuberculosis. It's not necessary that we have to use all the components of this. Depending upon the patient's scenario, depending about the amount of deformity, it limits that we can use 1 or 2 components of this in the surgical management of a particular patient. Anterior spinal tuberculosis anterior surgical management used to be very, very popular. But however, as we all aware, you should never do laminectomy alone without instrumentation in any spinal tuberculosis. We have seen disastrous results with this. Therefore, when you are operating on a TB spine patient, if you are doing a laminectomy, it should always be associated with or accompanied by spinal instrumentation. That's mandatory. Anterior surgery used to be very, very popular. The standard Hodgson method of anterior fusion, still popular in many places and depends on the training and the experience of the particular surgeon and what he believes in. But currently we don't do much of anterior surgery, that is an anterior approach surgery for these type of situations. But still in cervical tuberculosis, anterior approach is the mainstay of treatment. It could be a pure anterior approach, as you see in this particular scenario, or it could be an anteroposterior approach. The next came the anteroposterior approach, which may be necessary in certain scenario when the patient is not responding. And when you have a failure of management, drug therapy, when you want to have a better clearance, you can do a combined anteroposterior approach. But as things have strained, most of the things in the spine can be done from a posterior approach. And currently we favor to do most of this by a posterior approach, because we do know that posterior approach can achieve effective debridement, decompression, reconstitution of the vertebral column anteriorly, instrument from behind and correct the deformity. Therefore, everything you can do from a posterior approach. There are various types of posterior surgery. Number 1, posterior instrumentation with or without decompression. Number 2, transpedicular or transfacetal debridement and posterior closing with instrumentation. And number 3, an all posterior global reconstruction, which could be transfacetal, transpedicular, or a costo-transfasectomy approach. We have to understand, if you look at the healing phase pattern or the restabilization pattern in spinal tuberculosis, it depends upon the amount of vertebral body destruction. When the vertebral destruction is less, the facets are intact, it collapses and heals. Whereas when the vertebral destruction becomes significantly more, the dislocated facet tends to fall forward. And when there are 2 or 3 vertebral loss, then you get a significant deformity. Similarly, when you are operating, you have to look at how much vertebral body loss is there. If the vertebral body loss is lesser, you can get away just by doing a posterior stabilization. If the vertebral body loss is greater than 1 or 1.5 to 2, then you may have to do an anterior reconstruction as well. What are the concerns with the posterior only approach without debridement? The first concern is, will it completely resolution happens? There are studies shown, if you look at the MRC trials, which look at medical management, all the patients who are medically treated, even though there was a defect, they healed well, there was some degree of kyphosis. And studies by Govan et al. From the Turkish group, where they said there is no major problem when the bony destruction is less, when the kyphosis is about 20 to 30 degrees, it doesn't cause major problem, especially in the thoracic spinal tuberculosis and also in the lumbar tuberculosis. They'll heal by bit degree of collapse, but there is no major difference even at 10 years at follow. And we also know that immobilization by itself, when you do a posterior instrumentation, there is a stabilization effect. And along with antituberculous therapy, it can suppress the infection and patient can significantly become better. But is it always necessary? You think that, okay, if you do not reconstruct the anterior column, will the posterior instrumentation fail? There are certain basic principles. You should never distract the deceit level, number 1. Number 2, don't contour the rod too much. You allow the correction, whatever of kyphosis. Moment you position the patient prone, you can find that the kyphosis significantly become better. Bend the rod to whatever kyphosis the patient has got, especially in active spinal tuberculosis, so that you don't have higher chances of implant failure. And if you want, you can do a posterior column shortening. I'll discuss about it later. Rarely you may have to do an anterior column in this scenario. These are certain examples of a posterior only surgery. As you know, tuberculosis of the spine heals by bone fusion. There is some degree of loss of correction, but if you see in the end, there is a good block of bone. And especially in spinal tuberculosis involving the thoracic vertebra, the results are usually very good with posterior only stabilization. You need a good stability, a good implantation, and usually they will heal without any major problems. Similarly, one more example, but usually when you use a posterior only approach without reconstruction, that means it's a pauci segment disease. What do you mean by pauci segment disease? That is the involvement of the vertebra that is involved in tuberculosis, usually limited to 2 vertebrae. Very rarely the other vertebra, even though are involved, but they are not collapsed. Therefore, when you have a disease which is involved to a single 2 vertebral segment, that is only 2 vertebral bodies with the intervening disc, that is 1 functional spinal unit, usually you can safely get away by doing a posterior only approach. When it is possible to do posterior alone, pauci segment disease is the ideal one. Even when the 2 or 3 vertebral body involvement is there, you can use it provided the 3rd vertebral body is not significantly collapsed. Kyphosis should be less than 40 degrees. Elderly patient with severe pain, and when there is a multi-segmental tuberculosis, you can do a long segmented bypassing instrumentation with a good results. If there is a significant defect in the front, you can do what is called as a posterior shortening. You do a wide laminectomy and gently compress that element so that you will get a better correction. I show you now is basically this is the patient with the tuberculosis. There is a degree of kyphosis, but you see what we have done is after doing a wide laminectomy, you have just debrided a bit and gently shortened. You can see these 2 ends have come in contact, and this corrects the kyphosis. And when you compress, the stress on the implant also is significantly less, and this leads to a very good option. Even though I have shown that is a gap in the front, but actually the disease infected tissue will remain there. And once you compress this, it will correct the correction, and then it usually heals well. Similarly, one more example of a posterior debridement and a compression giving out a good results. But however, whenever there is a deformity, number 1, number 2, when there is a significant scoliosis or a significant kyphosis, whenever there is a deformity, you have to be necessary for you to do a decompression and anterior reconstruction. If it is a simple, like here, it's a pauci segment disease, that means it's involving 1, 2 vertebra and adjacent disc space. You can easily approach like a standard transforaminal lumbar interbody fusion or a TILIF. Here we have done a transforaminal lumbar interbody fusion. We have excised the facet joint, gone into the disc space, and have been able to achieve the correction. But when the deformity is significantly more, then you have to do a global reconstruction, that is costotransfixectomy, remove 2 or 3 ribs, approach from the side, and put a cage into the anterior aspect of the vertebral body, as you can see in this particular picture. One more example of a global reconstructions. In lumbar spine, try to save the motion segment. You always go transpedicular and try to save as much motion segments as possible. But as you know, in a spinal tuberculosis, if it's a pediatric, if the deformity can progress up to skeletal maturity. Therefore, it's important that we tend to follow them till the skeletal maturity and even thereafter every 2 years. Therefore, to conclude, uncomplicated spinal tuberculosis is a medical disease. If surgery is indicated, posterior only surgery is adequate in most surgeries. And in posterior only surgery, posterior instrumentation alone may be adequate in patients who have got less than single vertebral body vertebral loss, number 1. Number 2, even if the vertebral body loss is slightly higher, you can do a wide laminectomy, gently remove part of the diseased tissue from the back itself, which is there lying in front, give a gentle compression, which is called a spinal column shortening. Because the anterior disease is soft, you don't need to remove that. Usually they heal well without any major problem. Thank you very much.
Thank you, Dr. Sethi. It has been quite elaborate. And I think my question has been answered. Yes, Dr. Rajiv, have you got any question?
Till now, no questions.
So we can move on to the next.
Any panelist want to ask any question to Dr. Sethi? So
I think we can go ahead with Gautam's talk because
yeah. So at the end we'll have some discussion. Yeah. I'm pretty sure that some more couple of questions will come later on. So shall we move on to the next speaker? So may I call upon Dr. Gautam Javeri, who will be talking on decision making in osteoporotic vertebral compression fractures. Dr. Gautam Javeri, please share the slides.
Just 1 minute. Huh?
Yeah.
I've shared the slides, but I can't see it. Can you all see it?
Yeah, we can see it. Yeah.
Okay. Okay, that's because I have to start the video first. Now
So you can minimize the viewers window.
I can't seem to be able to see it.
Now we are also not able to see it. Now it has come.
Yeah. So at the outset, let me thank the members of the Bihar Orthopedic Association, Dr. V.K. Sinha, Dr. Rajiv Anand, and Dr. Huda for having us here. And on behalf of the Association of Spinal Surgeons of India, I am the Joint Organizing Secretary with Dr. Ajoy Shetty. And on behalf of our President, Dr. H.S. Chabra, our past President, Dr. Raghav Dutt, and future President, Dr. Shankaracharya, and the rest of the team, I would like to invite all our viewers for the Association of Spinal Surgeons of India conference, which is going to be held in Patna sometime in March. It is going to be a grand spectacle, and all the aspects of spine surgery, both for the general orthopedic surgeon as well as for people who are doing specialization in spine surgery, will be covered. It will be an exciting time to meet, network, so please do come and attend the meeting. Now moving to the talk which I have been asked to take, and that is on osteoporosis. Now, as you all know, our population is getting older, and all of you are seeing more and more of patients who are in the older age group. As a spine surgeon, I see about 2 to 3 patients with osteoporotic vertebral fractures every week. And in fact, if you look at osteoporosis as a disease, you will see in this chart that patients secondary to fragility fractures because of osteoporosis spend more days in the hospital per year than patients do for COPD, stroke, breast cancer, myocardial infarction, etc. So is it fair to say that a woman who is tall like this in her 30s and 40s at 75 or 80 is going to have multiple fractures and is going to become kyphotic like this? Is it fair to say that a man like this, who is otherwise slightly kyphotic during his young age, will become like this woman, completely hunched back when she grows older? Will a spine like this become a spine like this by the time the patient is 75? Or can we prevent this misery as spinal surgeons, as orthopedic surgeons? Vertebral fracture incidence is increasing with age. If you look over here, people who are 75 and above have almost a 35 to 40% incidence of vertebral fractures, osteoporotic. If you look at above 85, there's a 50% incidence of osteoporotic vertebral fractures in Caucasian women. And this number keeps on rising. The more the number of fractures and the worse the severity of the fracture is, the more is the risk of developing newer fractures in the future. And the risk of death following a spine fracture is much higher than the risk we see. All of you orthopedic surgeons are extremely afraid of a hip fracture because you know that the incidence of mortality within 1 year after a hip fracture is extremely high. That mortality is significantly higher with a spine fracture than it is for a hip fracture. And yet when these fractures come to you, when patients come to you following a trivial fall at home, we tend to ignore these fractures and we are not sure how to go about treating it. Over the next 20 minutes, I'm going to tell you about the rational approach to management of osteoporotic fractures, which I have developed over 30 years of experience, having treated thousands of patients. and from whatever I have gleaned through literature, etc. So here is this 70-year-old lady, a diabetic, hypertensive. She had a domestic fall 3 days ago, severe back pain, no lower limb pain. An X-ray was done, showed a osteoporotic compression fracture. Probably, I think this was L1. The question then was, how should we proceed? Should we do further investigations at this stage? Should we treat this patient, start non-operatively? She had a clear history of fall. This is an osteoporotic compression fracture. She is in pain, so should we directly do some sort of surgical procedure such as vertebroplasty or do a surgical stabilization of this? Well, whenever you have to treat a particular problem, you should know the natural history of the disease. Once you know now the natural history of a problem, it helps you to make rational decisions. So if you look at the natural history of osteoporotic vertebral fractures, you will realize that out of 100 patients develop osteoporotic fractures, about 63% of them will go on to normal healing. And this healing typically takes 4 to 6 weeks following injury, by which time about 65 to 70% of the patient's pain reduces by 80%. So the large majority of osteoporotic vertebral fractures are benign. They heal by themselves without collapse or with a little bit of collapse, and the pain reduces correspondingly over 4 to 6 weeks by almost 80%. Remaining 37% of patients will have a little bit of collapse of this fracture. Some fractures will collapse and then go on to heal in a kyphotic position, but without any pain, without any other problems. About 14% of fractures will not heal. And amongst these patients will have persistent pain, they will have deformity, they will have progressive collapse, and a small number of them will go on to develop what is called as a delayed neurologic deficit, because they will collapse delayed. Now, which are the fractures which are known to collapse late? If a patient has a simple wedge compression fracture where the posterior wall of the vertebral body is intact, the chances that the patient's fracture will collapse significantly and develop a neurologic deficit is rare. The fractures which do collapse are burst fractures, fractures where there is a ligament injury at the back, that is the posterior ligamentous structures are torn, or where there is a pseudoarthrosis, that is the non-union of the vertebral body. Typically, if you take a history of these patients, they will tell you that post the fracture, post the fall, they had pain in the back, but they were moving around. And 2 to 3 weeks later, they start developing wobbliness of the leg, unsteadiness of gait. Then they start eventually getting weakness in the leg. Typically, proximal thigh muscles are weak. People usually examine the ankle to foot, and therefore they miss this proximal weakness because of lack of suspicion, and patient becomes bedridden. What is, since majority of the patients are going to get better on their own without much treatment, what is the non-operative treatment? Bed rest for 2 to 3 days to 5 days is good. Prolonged bed rest, especially in these elderly patients, is extremely risky and harmful. With each passing day, the patient loses confidence in his ability to walk. Proprioception reduces, muscle weakness and atrophy sets in, joints become stiff, and of course there are other problems like osteoporosis increases, urinary tract infection, pulmonary embolism, and chest infection. And therefore bed rest is bad. A short period, 2 to 3 days, to get rid of the very severe acute pain, and then allowing the patient to mobilize as per comfort is what is recommended. Appropriate analgesia should be given. Generally, you must avoid neuropathic painkillers like gabapentin and pregabalin, and also tramadol and ultracet, because these make the patient more giddy and there is a higher likelihood to fall. It also makes them constipated and they are not comfortable. Generally, some kind of combination of drugs of paracetamol with a little anti-inflammatory and some amount of analgesia is what is required. Please start these patients. This is your opportunity to start them on anti-osteoporotic drugs. So start them on calcium, vitamin D, investigate the patient for blood tests. And there are lots of options now. Anti-osteoporotic agents which are typically used are bisphosphonates, either oral or IV, or you could use denosumab or teriparatide. These are basically the options that are available in today's day and age for osteoporosis. What has been found to help osteoporosis is exercise. And generally, what happens is, since the patient has a fracture, the physiotherapist, and you send him to a physiotherapist, the physiotherapist refuses to give flexion exercise for fear of worsening the collapse. The problem is these patients have a stiff spine. If you give them extension exercises, they will be even more painful. And therefore, what is recommended is flexion exercises, gentle isometric strengthening of the muscles, and aerobic exercises like walking are the best thing. In the long term, muscle strengthening in muscle training is what is going to help them the most. Finally, bracing. Because there is a fracture, we have all been used to giving bracing for fractures. But for osteoporotic vertebral fractures in the elderly, I do not like braces. Braces are heavy. A lot of the fragile elderly patients cannot bear the weight of brace. They are naturally slightly hunched. If you give them a brace, they are very uncomfortable in this hunched position wearing an anterior hyperextension brace. The Taylor's brace really doesn't give much support. And finally, if you give them a brace which pushes them into extension, the arthritis in the facet joints makes them painful. So they are never happy with a brace, and I almost never prescribe braces for these patients. Well, going to this lady whom we were talking about, who had a fall 3 days back, we started her on conservative treatment. But 6 weeks later, she was still complaining of persistent pain, worsening back pain. She said that, you know, a lot of the original severe continuous pain had gone down, but now pain was there when she turned in bed, when she got up from lying down to sitting or sitting to standing position. And she had limited sitting or standing tolerance. She could sit and stand comfortably for some time, but after some time, the pain and fatigue tended to set in. The question now was, how should we proceed? Should we continue the non-operative treatment, thinking that, oh, she's had a little bit of relief in that continuous pain? Should we investigate this further? She's 6 weeks down the line. She's had adequate amount of time to recover. Should we directly go for vertebroplasty in these patients, or should we go for a surgical stabilization? So the answer would of course be that we should investigate the patient. The why? The first thing you want to confirm is that the fracture, the vertebra which we are seeing on X-ray as a fracture, is in fact the source of pain. You want to rule out other causes of axial back pain. The third reason being, you want to rule out other causes of vertebral compression fractures, rule out ligamentous instability, study the morphologic of the fracture, and finally to evaluate the amount of osteoporosis, the cause of osteoporosis, because you need to plan anti-osteoporotic medicine, and in order to plan that medication, you require some basic blood tests. So step one is identifying the painful vertebra. Often patients with back osteoporotic vertebral fractures will complain of little tenderness or pain at the site of the fracture. Most often, if you see 4 to 6 weeks later, the pain is more axial, lower down in the lower back and not at L1. It is over the iliac crest, it is there in the lower back, and it confuses you. Some patients have multiple fractures, like you can see in the MRI over here. So which fractures are painful? Painful fractures are those which have tenderness over the fracture site clinically, and on MRI there is a hypointense signal on T1 and hyperintense signal on T2 image. So if you see this image, this fracture is an old fracture and not the cause of the current pain. The current pain is coming from the patient having an L4, L5 injury. Another test you can do if you want is to do a bone scan. If the bone scan shows a hot spot, then again you are confirmed that this is in fact the painful vertebra. The second step is to confirm that there is no other cause of axial back pain. Is the back pain because of facetal arthropathy, degenerative spondylolisthesis, arthritis of the sacroiliac joint, or associated fractures in the sacrum of pelvis? So get x-rays done, rule this out. The third step is typical central osteoporotic vertebral body fracture is a central lesion. A central vertebral tuberculosis can look very mimic a osteoporotic vertebral fracture, and so also a patient with a metastatic spinal tumor with a solitary vertebral collapse could mimic a vertebral fracture. So how do you differentiate? If you see this MRI here, a typical patient with a vertebral collapse may have reduction in disc space in infections. There could be evidence of collection which is passing subligamentous either anteriorly or posteriorly to the adjacent vertebral bodies, and there is an epidural spread of infection. In an MRI, there may in a patient with metastasis, there may be often ballooning of the vertebra. There may be a posterior signal intensity change within the posterior half of the vertebra, which is typical in a metastatic tumor. Step 4 is to find out what type of fracture is it. Basic typical fractures are an AO type A or a type B fracture. A type A fracture, which is the one you see on the right, is a fracture which involves only the vertebral body. There is no injury to the posterior ligamentous structure. This is basically a stable fracture. The other type of fracture is the AO type B fracture, where there may be a compression fracture anteriorly. That is not important. What is important is that the posterior ligamentous structures are torn. And therefore, when there is this type of a situation, the instability is between two vertebrae. And therefore, by treating this vertebra with a vertebroplasty, you will not be able to achieve stability. So, AO type B fracture has to be treated with surgery. A AO type A fracture is one which has intravertebral instability. That is, the void is within the vertebra, and therefore there is pain. So these type of patients can be treated with vertebroplasty. Let me give you an example. This 86-year-old lady had a bit of a fall at home in Pune. She developed this kind of a compression fracture. She immediately went and saw an orthopedic spine surgeon, and she told the spine surgeon, "Sir, when I'm lying down, I'm absolutely comfortable. But when I sit or stand, I get severe back pain. What should I do?" So the surgeon in Pune treated her with this kind of a vertebroplasty over here. Patient was not much better. She felt the same complaints were still persisting. So she came to Bombay, and she saw a spine surgeon in Bombay and said, "Sir, when I'm lying down, I'm absolutely fine. But when I stand and walk, I get severe back pain." So the person in Bombay, as all Bombayites are prone to do, thought that, look, the Pune person did not do the surgery properly, so I will do the surgery, and repeated the vertebroplasty. So this is what he did. A second vertebroplasty was done. The patient said, "Sir, before the vertebroplasty, I was comfortable when lying down, and I got pain when sitting. Even now, I have the same complaints. What should I do?" So now she went and saw a neurosurgeon. The neurosurgeon thinks that everything is because of nerve compression. So he did an L4-5 laminectomy decompression, and post-operatively the patient said, "Doctor, when I'm lying down, I'm absolutely fine. But when I sit, I still have back pain." Now what should she do? She had seen multiple doctors, no relief. What should she do? Well, she decided to do the wise thing. She came to me. And when she came to me, I got some sitting x-rays. And you can see on the sitting x-rays, the whole spine is collapsing into kyphosis. The posterior ligaments are opening up. Interspinous interval is opening up because the ligaments are... So this was in fact a type B fracture with intervertebral instability, which can never get better with a vertebroplasty. On the other hand, what do I mean by intervertebral instability? This is a patient with ankylosing spondylitis who had developed this vertebral compression fracture. Now, the plan for him was, and he had a severe kyphosis because of angspont, so we were going to operate on him for this. When we positioned the patient prone, his vertebral body completely opened up and became normal height. And you can see the huge gap which has occurred within the vertebral body. This is what is called as the intravertebral gap, void or instability, which is there because the cancellous bone gets compressed over here. And this is the type of patient who would respond to a vertebroplasty normally. Sometimes we require additional investigation to study the morphology of a complex fracture, in which case a CT scan is done in order to evaluate the fracture better. The final step in the decision making process is to evaluate the severity of osteoporosis using DEXA scan, quantitative CT, etc. You need to find out the cause of osteoporosis, whether it is alcohol, smoking, etc. And you want to do tests in order to evaluate the patient in terms of the medical treatment you are giving in. For example, a patient who has a high creatinine may not be a good candidate for bisphosphonates. And a person with a past history of malignancy may not be a good candidate for teriparatide. So you need to investigate the patient with this in mind. Now coming back to our 70-year-old lady, diabetic, hypertensive, who had a fall, severe back pain, no lower limb complaints. She had persistent pain after 6 weeks. What should we do in her? Well, what we did was dynamic x-rays. We did x-rays with her in supine and in standing position. And you can see that this vertebral body is completely collapsing when she goes from supine to standing. And that means that there is frank mobility within the vertebra. This is an intravertebral instability, which probably requires a vertebroplasty. Toyone et al. Showed this very clearly, that there is a significant correlation between changes in the vertebral body wedging on dynamic x-rays and the amount of back pain the patient has in patients with osteoporotic fracture. The patient, of course, was investigated. Most of the stuff was normal, but her DEXA scan showed a T-score of -3.1. Question was, how do we proceed? Well, I showed you that she had an intravertebral collapse. So the option was of percutaneous vertebral cement augmentation procedures. There are 3 types of procedures which are commonly used now in practice for cement augmentation of the vertebra. The first of is injection of PMMA cement or even biological cements into the vertebra, what is called as a vertebroplasty, without trying to change the kyphosis actively. The second is a procedure called as balloon kyphoplasty, where a needle is inserted into the vertebra. A balloon is put through the needle. The balloon is expanded. When you expand, the height of the vertebral body increases, creating a void within the vertebral body. The balloon is removed and then the cement is injected. The theoretical advantage is it helps to create an improvement in height. It is supposed to have a lesser risk of pulmonary embolism and a lesser risk of cement leakage from the vertebra into the epidural space or outside. The third type of procedure is the vertebral stenting. The problem here in kyphoplasty was that when you remove the balloon, the vertebra tends to collapse a little bit more. And then you are injecting the cement. To prevent that, vertebral stenting has been put in, where the cement is injected whilst the stent is inside. When should you do a cement augmentation of the vertebra? When there is a painful AO type A compression fracture, which means a vertebral compression fracture without any ligamentous injury at the back, which is treated primarily non-operatively, but even after 4 to 6 weeks of non-operative treatment, patient has persistent pain. We use this vertebroplasty in patients with chronic vertebral fractures with persistent bone marrow edema and non-union. And we sometimes use it in acute painful fractures in elderly patients where immobility may pose health hazards, such as in patients commonly with liver cirrhosis, renal transplant or dialysis patients. Nowadays, we are seeing more and more of these patients who are otherwise bone quality is very poor and therefore they require a vertebroplasty when they develop fractures. There are many contraindications to vertebroplasty. If the patient is asymptomatic, irrespective of whether he has a compression fracture or not, whether it is hyperintense or not, he does not require any procedure. A patient who has a ligamentous injury, which is the AO type B and C fractures, should not be treated with vertebral augmentation. They require formal surgery. The X-ray I showed you some time back of the intravertebral defect where the vertebra had opened up. If there is such a large intravertebral defect, the amount of cement which is required is far more than the amount of bone which is there. cement becomes a very rigid thing within a soft bone capsule or envelope, and the bone then collapses around that. So therefore, in patients with very large defects, you should not try to do a vertebroplasty, it will fail. The next one is if there is a wall defect in the anterior wall or posterior wall. This is a relative indication, a contraindication. We can still do it using various techniques. We can still manage to do a vertebroplasty in these patients. Sometimes if a patient has a very severe vertebral compression fracture, vertebra plana, putting in cement there may be difficult and may not serve much purpose. There is a small risk of cement embolism in these patients. And therefore, if the patient already has pre-existing severe respiratory disease, probably a normal patient may tolerate the minor embolism, but a patient with already pre-existing respiratory disease may not be able to do so, and therefore you should avoid vertebroplasty in these patients. Of course, infection and coagulopathy. So here is an example, a 75-year-old male with severe activity-related back pain for 4 months, was bedridden, and vertebroplasty showed very good results. We did a study for 8 years between 2002 March and 2010 December. 107 cases, 1.2 level average vertebroplasty was done. Almost 95% of patients had excellent pain relief within 24 to 48 hours, became mobile and functional. It's a dramatic procedure. Patient comes to you in the morning on a stretcher and goes home in the evening walking if you have selected the right patient and done the procedure properly. What have been our complications? We had one death in the very early part of our studies when patient had a cement embolism and died. We had one patient who fell subsequently and had a recurrent fracture where the cement got dislodged backwards and caused a delayed neurologic death. Now, those patients who have an unstable type of fracture where posterior ligamentous injury is there, patients who have a neurologic deficits, those with severe deformity because of multiple fractures, those with a large intravertebral defect, all these patients will, or there is some other contraindication to vertebroplasty, will require a surgical stabilization. Surgical stabilization in this age group is not easy. Patients have multiple medical comorbidities, they are frail, they are mentally not very well there. Anterior column reconstruction is a challenge because the bone is extremely osteoporotic, but it is extremely necessary. There is a problem with adequate implant purchase because the bone quality is poor, the implants may not hold. There is failure because when you put screws and rods in a particular segment, all the load gets transmitted at the end of the screws, and therefore there is a chance of proximal and distal junctional failure. And of course, osteoporosis means fusion is a difficulty. Well, how do you overcome the problem of poor purchase of the screws and rods? One option is to supplement them with either hooks or sublaminar wires. Another option is you make sure that the pedicle screws are put, you under tap them. Suppose you're putting a 6.5 mm screw, you tap only 4.5. And use thicker screws as much as possible, use longer screws. Sometimes I will try in these patients to go for a bicortical purchase in the vertebra in order to stabilize it better. Make sure you triangulate the screws adequately, and you can augment the screws using cement injection. There are screws called as fenestrated screws where there are holes at the tip of the screw through which you can inject cement for better hold. And there are expandable pedicle screws where the tip expands so that it has a better per screw purchase. And one of the newer techniques which has come is instead of putting pedicle screws which are directed medially, put shorter screws going laterally across the lamina through the pedicle called as cortical screws, which have a better purchase than the typical pedicle screws. Anterior surgery alone is never an option in severely osteoporotic patients because the anterior screws will not have any purchase in the cancellous vertebral body and will back out in no time at all. Therefore, what is preferable is posterior surgery or a combination of posterior and anterior surgery. This was a 67-year-old lady who came with back pain and paraparesis. She was unable to walk. There was a vertebral compression fracture with multiple level stenosis at the bottom. So what I did was that I decided that we will decompress and leave without correcting the fracture deformity. We'll fix it inside too. And we also did decompression for the spinal stenosis, fixed it with intersублaminar wires. This patient went on to recover completely and did extremely well. Another procedure that could be done is what is worse for implant is if that there is no anterior column support. As Dr. Shetty mentioned in his lecture, anterior column support is vital. Either you can do it with bone graft, you can do it with cages, you can do it with vertebroplasty, or you can do it with what is called as vertebral column shortening procedure. I described this way back in 2005 for the use of acute thoracolumbar fractures in tuberculosis and in osteoporosis, and this has become very popular over the last 15 years. What you do is already there is a compression fracture at the front. You excise the pedicle laminae spinous process from the back, and then instead of distracting, you compress so that this superior end plate comes in contact with the inferior end plate and gives strength and stability to the entire side. As you can see in these pictures. So here is a lumbar spine fracture at L3, where I went from the back and instead of distracting, I compressed gently so that the whole vertebra got impacted and prevented failure of the implants. The last thing you can do is vertebroplasty plus posterior stabilization. So as I said, restoring the anterior column weight bearing mechanics is extremely important. So as I've done in this patient, you can do a vertebroplasty at the level of the fracture and then stabilize it from the back to prevent further collapse of the vertebral body. When there is poor purchase, I regularly use sublaminar wires at the levels where I put the screws also, and that offers better stability. Here is a 79-year-old lady who presented to us about 3 weeks after a fall, severe back pain, paraparesis, inability to walk. We did a posterior vertebroplasty at multiple levels, decompressed the spinal cord, and put in heart shield with sublaminars with excellent result. This is the patient at a 4-year follow-up doing extremely well, walking normally, neurology was normal. Finally, rarely you require a combined anterior plus posterior surgery. It is a big ask in these elderly patients. So here is a lady in whom I had done a heart shield sublaminar wire fixation and decompression for osteoporotic vertebral fracture with neurologic deficit. Neurology improved. She was doing very well. But 6 months later, she came back to me with breakage of the, with recurrent subluxation over there and breakage of the wires. And we had to redo the fixation where we went in from the back, stabilized it with screws, and then went in from the front. And you must realize that when you have osteoporosis, you require more purchase in the bone, and therefore don't restrict yourself to one level above, one level below. Try to go even 2 or 3 levels. There is no harm. You have to provide adequate stability to the part so that the implant doesn't pull out or fail. Don't try too much of correction of deformity. Fix the vertebral fracture in situ in order to prevent failure of implants. Finally,
Dr. Gautam,
let me just...
we are not left with much time for questions. So you are answering almost every question.
Last slide. But finally, what is most important is after all this, if you do not give good anti-osteoporotic agents, the whole surgery is a waste. This is a patient, for example, in which I used teriparatide following an osteoporotic vertebral fracture, and you can see the florid bone formation which occurred within 6 months. This patient went on to heal very well. So this is our results of patients with neurologic deficits over a 13-year period. We did 52 cases, and all of them went on to do very well. So my conclusions, you must remember that osteoporotic vertebral fracture is a mechanical sequelae of a biological problem. Today, osteoporotic vertebral fractures have become a global emergency. Every second, one new osteoporotic vertebral fracture occurs across the world. And the basic treatment is medical treatment, calcium, vitamin D, and adequate exercise. 65% of osteoporotic vertebral fractures will heal without problems. If patient has persistent pain, progressive pain after 4 to 6 weeks, always rule out infection and metastasis. If patients have a burst fracture, a ligamentous injury, or a pseudoarthrosis, there is a risk of delayed collapse and a late neurologic deficit. If the patient has pain without instability, without neurology, then vertebroplasty is an option. In all other patients who require some kind of surgical stabilization would be the goal. Thank you very much.
Dr. Rajiv, any question?
Yeah. Thank you so much, sir. Such a very nice presentation. One of the viewers, Dr. Abhishek Sarraf from Darbhanga, has a question for Dr. Gautam Javeri. That what is your experience with denosumab in osteoporotic fractures? Is it superior to teriparatide? Kindly guide us for its indication.
So denosumab has come into picture only over the last 2 to 3 years in India, and therefore long-term Indian studies are not available. Whatever studies are there are from abroad. However, what I find is that denosumab is an anti-resorptive agent. It is not like teriparatide, which is actually a bone forming agent. So obviously teriparatide is a far better drug than denosumab. The advantage of denosumab are threefold. One, that it does not require to be administered daily. It is administered once in 6 months. So not only is there ease of administration, it is also cost is lesser. But the third part is the complications are also lesser. Now, denosumab can be given in patients who are already on renal dialysis, who have other kidney problems, which all your zoledronic acid and all cannot be given. So that is the advantage of denosumab, and denosumab works very well, but not as effectively as teriparatide.
Thank you, sir. And one of the questions to all the panelists, Dr. Ratish Mishra, he has asked that what is the treatment of intervertebral instability? Just posterior stabilization or combined anterior and posterior approach should be done?
So let me take this the question here. So when you talk about intervertebral instability, there can be two types of pathologies. One is where there is only a ligamentous injury at the back and the anterior vertebral structures are relatively intact. In these patients, only posterior stabilization is enough. But suppose the patient has also, along with the intervertebral instability, ligamentous failure at the back, has got severe collapse of the vertebral body anteriorly, or as in tuberculosis, as Ajoy would say, that if there is an anterior gap which is formed because of the destruction of the vertebral body, then you need to reconstruct the anterior column as well. 80% of human body loads are borne by the anterior column, which consists of the vertebral body and disc. If your vertebral body disc is not restored, then the implant which you put at the back becomes a load-bearing implant. And we all know from orthopedics that load-bearing implants fail eventually. So what you need to do is to convert a load-bearing situation into a load-sharing situation. And for that, anterior column reconstruction is vital when there is an inadequate anterior column. I hope that answers his question. Any
comment?
No, I agree with Gautam, but what you should understand is that in Gautam said, anterior column reconstruction is mandatory. It didn't mean that you have to go in from anterior, do a corpectomy and reconstruct. You can reconstruct either by shortening, number one. You can reconstruct even by doing a vertebroplasty along with
So there are three methods of reconstructing from the back itself. One method of reconstructing is by just leaving, don't correct the deformity, keep it in situ. So that bone is already against bone, you are not creating a fresh void. So in tuberculosis, for example, the older method of treatment was to do a vigorous debridement. Nowadays, we don't do debridement that much because that granulation tissue infection is going to heal with anti-tuberculous drugs. What we want to do is only stabilize, and therefore we stabilize from the back, decompress the neural structures, and we don't try to remove much from between the vertebral bodies because that creates a defect which then has to be filled. So you can leave it inside too if the deformity is not very bad and the gap is not too bad. Or if you feel the gap is small, like in a paradiscal lesion, then you can do what vertebral shortening, what Ajay showed, where in a vertebral shortening, you will have to remove the lateral pillars on both sides and then shorten between the pedicle screws by compressing, so that anteriorly the vertebral body will come in touch with the vertebral body below. And the third type of reconstruction is where you would go, if there is a much larger defect than that, then you would have to go in from the side through a posterolateral transpedicular or extrapedicular approach and put in some kind of anterior reconstruction using from the back only, from posterior approach, using either bone graft, strut graft, or using a cage. Now, this is of course a subject. Now, suppose the defect is purely within the vertebral body, like it is in an osteoporotic vertebral fracture, then you can choose to reconstruct it with bone cement. You inject bone cement through the vertebral body and use that as an anterior reconstruction. And posterior reconstruction is done with screws and all.
So I think we should
Thank
conclude.
you. One more question to Dr. Somajit Basu, please. There is a question that there is a fracture of odontoid type 2 with a ring fracture of C1. Invariably, it is missed in MRI. How to diagnose it and what should be the treatment?
Come again once. There is a type 2 odontoid fracture. After that, what did you say?
With the fracture of ring fracture of C1.
So if there is a type 2 odontoid fracture of this C2, then whether you have an additional fracture of the C1 or not is of lesser importance, because a type 2 displaced fracture means that you need to operate upon it. Now, if it is undisplaced and the C1 fracture is also undisplaced, I would definitely immobilize an halo.
Yeah.
Serves me good. If it is displaced, it's just on the principles of a C2 odontoid fracture.
C2 only treating alone C2 odontoid fracture is enough. Nothing to do with the C1 ring fracture from the posterior spinous wire or something. You don't.
No, I would operate on C1 C2 fusion. Now, C1 C2 fusion means that I'll have to put in some metal work at C1 and at C2. Now, the C1 metal work is at the lateral mass by Goelham's technique. If the C1 lateral mass is completely shattered, would not hold anything, then I'll have to go up to the occiput. But otherwise, I'll be hell-bent observing the occiput and not fusing the C0 C1 joint.
Thank you, sir. So I think the time is over. I think it is 10 past 2.
Yes,
So we can extend 15 more minutes, sir.
yes, I can. Yes, I will take few minutes.
Yeah.
Can I? Yes.
Yeah, sure.
So, I must thank all the participants, and a special thank goes to those who are listening to our webinar. I think in post-corona world, perhaps this webinar type of conferences is going to be the method of spreading the scientific knowledge and personal experience. So I think we must practice it more and more. And if the time allows, we will organize more such webinars, especially in context of SCCon. So I think the presenters have been so wonderful and explicit to their presentation that one need not to comment upon it, or I think the only comment is that they were just wonderful. So I will request in the last to all the listeners and the participants to please be ready and help for preparing a great, grand and Gala SCCon 2021 at Patna to be held in the last week of February, that is 25th February to 28th February. And thank you very much.
Okay, thank you everyone. Thank you.
Namaskar.
Thank you, sir. Thank you.
Gautam
Thank you
sir,
all.
Ajay, Basu, Dr. Hotan,
Thank you, sir.
everyone else. Thank you.
Thank you, sir. Thank you.
Nobody
Thank
thanked
you,
me.
Thank you all. Thank you all the viewers.
Thank you.
Thank you, sir. We are ending the live stream right now, sir.
Yeah.
So how many viewers are there, Samsul?
In total, including the Ortho TV website and YouTube, it was more than 1,000, sir.
That's wonderful. 1,000 is quite good.
If even
1,000.
10% of these people come to the meeting, will be successful.
Yeah.
Yes, sir. Okay,
Dr.
sir.
Sethi. Dr. Sethi. Dr. Ajay.
He has left.
He has left.
Oh,
I think.
he has left.
Okay, thank you. Thank you.
Okay, sir.
all
Thank you,
the-
sir. We're ending here, sir. Thank you, sir.
Yeah.
Thank you, Dr. Samshul, Dr. Rajiv. Personal thanks
Okay.
to you.
And at last, I thank all the viewers